All right. Well, everyone, we are here to discuss our patient, Marilyn Smith, a 28-year-old female. Um, so, Marilyn Smith is a single African American 28-year-old female who presents to the emergency department with complaints of feeling crummy for the past 6 months. She reports she no longer feels like doing any of the things she used to enjoy. She states that it all seems so pointless. She can't even bother to eat most days and has lost weight recently. Although she has no energy, she finds it difficult to both fall asleep and stay asleep. And she says that even when she does fall asleep, she never feels well rested when she wakes up. She reports having difficulty at work as a computer support person because it's hard for her to concentrate. Last week, she called in sick and spent the day in bed crying off and on all day. Last night, she found herself crying again, and this time she also thought about suicide, which scared her and prompted her visit to the ED today. She said she does not want to live like this anymore and that she feels like she will never be happy. Her personal social history is that she graduated from high school and obtained an associate degree in computer science. She enlisted in the Army to have an adventure and hoped the GI Bill would pay for further education once she completed her service. She reports still feeling guilty about making the decision to enlist instead of marrying her high school sweetheart. She was deployed to Iraq and returned home a year ago. She enjoyed her time in the service because she felt like she was doing something useful for her country. She did not see combat and did not experience any significant problems while in Iraq. When she returned home, she found her old boyfriend had married. She recently attempted to contact local universities to explore completing her baccalaureate, but found the process too overwhelming and just gave up. When questioned about alcohol or drugs, Marilyn reported she is an occasional drinker, but admitted recently she's been drinking more in an attempt to sleep. She denies any other drug use and has no diagnosed clinical history or history of clinical depression. Her grandmother, though, she says, had periods of becoming withdrawn and not leaving the house for days. So, aspects of her history that are relevant and have clinical significance, primarily her complaints of feeling crummy. She appears to endorse a persistent low mood that has lasted for quite a while, and a low mood lasting longer or 6 months or longer can suggest, chronic condition of depression, possibly major depressive disorder. Depression that endures for this length of time without intervention can lead to worsening mental health and worsening physical health and increased risk of functional decline as a heightened risk of suicidal ideation. Um, Marilyn presents with anhedonia, a primary symptom of major depressive disorder, reflecting a significant loss of motivation and pleasure in activities she previously enjoyed. It serves as a key indicator of her depression and its severity and is frequently associated with emotional withdrawal and social isolation, both of which can severely diminish her quality of life. Her loss of appetite and recent weight loss, which appears unintentional, is also concerning. Her significant weight loss and decreased appetite is a physical manifestation of depression and may lead to malnutrition and compromised immune function, further aggravating fatigue and emotional distress. This symptom also heightens concern for neglect of self care and health maintenance. Lack of energy also feeds into that train of thought. Fatigue is commonly associated with depression and results in diminished ability to perform daily activities. Prolonged fatigue can exacerbate feelings of worthlessness, helplessness, and further withdrawal from work and social activities, perpetuating a cycle of worsening mental health. She endorses difficulty falling and staying asleep and feeling unrested upon waking. Sleep disturbances, including insomnia and poor quality of sleep, are common in depression. Insufficient rest contributes to cognitive impairment, worsens emotional dysregulation, and can increase irritability, hopelessness, and potentially bolster the potential for suicidal ideation. Restorative sleep, as we all know, is essential for emotional resilience. Difficulty concentrating at work, resulting in absenteeism. Another manifestation of depression that can worsen her cognitive impairment, particularly her difficulty concentrating. It impacts her work performance, and the absenteeism is concerning because it could jeopardize her job security and financial stability, which in turn can feed into a cycle of feelings of hopelessness and inadequacy. Crying episodes are particularly concerning. This emotional lability and withdrawal is definitely a significant indicator of distress and worsening depressive state. These behaviors suggest potential for complete disengagement from normal functioning, increasing the risk of severe depression and social isolation. Thoughts of suicide, obviously, this constitutes a psychiatric emergency, and we're glad that Marilyn has come to seek our help today. She she definitely, it is promising that she recognized that this is a deeply concerning symptom and has sought help. And as we know, without intervention, Marilyn is at significantly increased risk of self-harm. Her statements of hopelessness additionally feed into this narrative. Feelings of hopelessness are closely linked to suicidal ideation and represent a major indicator of severe depression. Her statements suggest a loss of perceived meaning in life, increased urgency for intervention, or increasing the urgency for intervention to prevent self-harm and address Marilyn's emotional state and worsening self-esteem. Her relevant social history includes her recent history of deployment, her status as an Army veteran, and her return home. Transitioning from military service to civilian life is often a challenging process, potentially leading to adjustment disorders, depression, or post-traumatic stress disorder. Even without the trauma of combat exposure, the loss of military structure and purpose is likely an exacerbating factor of Marilyn's depressive symptoms, contributing to her current decline in mental health. She expresses regret over the loss of what appears to be a very significant relationship, her high school sweetheart, who she learned married while she was deployed. The emotional impact of losing a significant relationship can lead to feelings of guilt, regret, unresolved grief. These unresolved emotions may contribute to her current depressive state, adding to her sense of loss and hopelessness. Emotional stress related to the end of this relationship could deepen her feelings of isolation and despair. Feeling overwhelmed by the process of exploring further avenues for education, she, had stated an original goal of wanting to use the GI Bill to further her education, but expressed that pursuing this process upon returning home has left her feeling extremely overwhelmed, and this serves as an indication of impaired cognition, or impaired cognitive function and motivation, which are common in depression. The inability to pursue her personal and professional goals can contribute to these feelings of inadequacy, further reinforcing depressive symptoms. Although she has no prior history of clinical depression, she does report her grandmother had periods of becoming withdrawn and not leaving the house for days. While Marilyn doesn't have a personal history, she describes behaviors in a family member that suggest a possible genetic predisposition for mood disorders. The family history may influence her risk for developing depression, and the similar symptoms in her grandmother may highlight a recurring pattern in her family, especially in one or a pattern that's exhibited in a family member that's removed enough to have occurred at a time where there was less of an awareness of mental health, and that behavior may have been categorized as withdrawn, or may not have been given the appropriate consideration that it would have been given should it have been happening today. And finally, she endorses increased alcohol consumption for the purpose of falling asleep. Increased alcohol use is as a coping mechanism for sleep disturbances can definitely worsen depressive symptoms and contributes to the development of a like cycle of attempts to self-medicate, which can lead to alcohol dependence. Alcohol also is known to disrupt sleep patterns further, exacerbating fatigue, cognitive impairment, and emotional dysregulation. Self-medication with alcohol poses inherent risks and may put Marilyn in a position where she could actually be doing herself more harm in terms of her ability to engage actively with any active issues in her life, just by merit of impaired decision making and worsening mental health. Her current vital signs.
Right before we move on to the vital signs, I did just want to throw in real quick. You mentioned that she has difficulty with losing that high school relationship. And I think it's worth just pointing out that she is 28, so that was quite a long time ago. So that could represent an abnormal um, connection or feeling of loss there that is also chronic in nature or newly coming up because of this acute state that she's in. Um, but I did just want to put a pin in that of like, this is an abnormal symptom that we're seeing.
I appreciate that, Kat. That you're absolutely right. That longing, it does seem disproportionate to the time that has passed. And while it's absolutely worth exploring Marilyn's thoughts on her prior relationship, because we don't want to minimize its significance to her, but at the same time, it does feel like an exacerbating factor. So that's definitely worth exploring further. To go over her vital signs quickly, they all appear to be very much within normal range, which is reassuring in the sense that Marilyn's vital signs and current pain assessment all fall within normal limits. And the stable vital signs suggest that her current symptoms are not necessarily driven by an acute medical condition, such as an infection or cardiovascular instability, but are more likely a result of her underlying mental health condition, specifically depression. The absence of physiological abnormalities shifts the clinical focus toward addressing her emotional state, including her feelings of hopelessness, lack of energy, and reported suicidal ideation. It also clears the way for us to explore her lab results because it is important to really rule out whether or not there's a physiological basis for how she's feeling.
Okay, so we can move on to the mental status exam. Some relevant assessment data was how she appears somewhat disheveled. This may indicate a lack of sleep, as you mentioned, Aislinn. Depression often impacts one's ability to get routine sleep and adequate sleep in order to function properly. Um, they also revealed in the MSC that she has slow speech and slow response. So, a slow reaction time shows a decline in psychomotor functioning. This is common finding in patients experiencing depression. She also has feelings of hopelessness. She's sad and anxious all the time. She was found like wringing her hands, kind of fidgeting. So these mood findings are consistent with depression. Constant wringing of her hands or fidgeting is consistent with anxiety that may be seen in someone with depression, as two often go hand in hand. Um, Feelings of guilt with no reason, worthlessness, which is a key feature that is common in clients with depression. Again, kind of reiterating a lot what was said. Marilyn's depression may have progressed into major depressive disorder because it has lasted for 2 weeks or more. She has stated that she's been having a lot of these feelings for the past 6 months. So next is her hallucinations. She's hearing someone at night. She says she knows that they're not real, but she's still hearing something. And so this is someone who's experiencing hallucinations is considered having major depressive disorder or an episode. She states that she does not feel right. So when a client admits they do not feel right, I think it's important that the nurse takes this seriously. Her other MSD assessment data are consistent with unregulated emotions or feelings that limit her ability to function daily. These indicate a state of depression. I also think it's important to point out that her judgment is intact, as evident by her coming here to get help. So we can agree that, like her saying, "I do not feel right," she's correct. So that's something that we like to note. Problems with concentration and cognition. Um, like Aislinn stated, patients with depression often have a hard time focusing on a task at hand and find it hard to complete things they normally would not have difficulties with. In other words, this is impacting her ability to function appropriately in her day-to-day life. And then her isolating behaviors, withdrawing from friends, and having little interest in her social activities is a key component of depression. And inertia or lack of energy combined with other depressive symptoms may be the cause. Withdrawal for an extended period of time may indicate that the client has progressed to severe depression with likely possibility of major depression as evident by her other MSE data. And then lastly, her suicidal ideations with access to a gun at home. Very, very important that we address this. She does not state that she is going to act on it. She does not state that she has a plan. But if we do not nip this in the bud, this could be a huge safety concern for her. She needs to get urgent treatment, and we need to make sure she's safe. Okay. So, current assessment data. Let's see. She appears tired and anxious, but all other physical assessment data are within normal limits, not clinically significant at this time. Like Aislinn said, her mental status is of importance in this situation. Her physical assessment data appear to have all normal findings. It is important to note her general anxious and tired appearance, which is consistent with someone who might have depression and specifically severe major depression in her case. Um, but we will continue to like keep this ongoing and monitor this because it can increase abnormalities in her physical assessment if her state progresses even further.
That was
Yeah,
really
I think
Very nice.
especially like Aislinn mentioned with a lot of the lack of eating, the lack of sleeping, all of that, I think it's a good point that even while vital signs are good right now, it's an important thing to keep checking out because those she is doing the things or her behavior is such that we could expect those to change kind of soon. Like her weight has changed.
Yeah.
So
absolutely. And with malnutrition or deficient intake, she is susceptible to vitamin deficiencies that can compound her mood dysregulation, that can make her feel even worse. I really appreciate, Stevie's ability to really hone in on the scary parts of this assessment data, particularly her access to a gun at home, because even though she's demonstrated some positive insight here, we can't necessarily rely on that to hold because as depression mounts, it she is she's in a very scary situation. And perhaps as we build our trust with her, it may be worthwhile to see if she would be comfortable forfeiting that weapon over to a family member who can get it out of the house. Because when people are in such a low place, it can become even easier to find a permanent solution to an impermanent problem.
Yeah. Yep, that's very true. Um, On to the lab results. There is not a whole lot to report here. All of the electrolytes and the glucose or creatinine all within normal limits. The CBC was mostly unremarkable, except for a low neutrophil percentage. And then her thyroid panel, the only exception here was the elevated T3. And, given her behavioral symptoms, I was thinking maybe hypothyroidism, but the elevated T3 combined with the um, can cause the lower neutrophil percentage. But elevated T3 does indicates maybe mild hyperthyroidism, which doesn't really align with the behavioral symptoms that she has been having. So overall, I would say that her labs are mostly unremarkable and probably not having any major impact on her behavioral and mental health situation right now.
I do want to say that elevated T3 levels are associated with increased alcohol use.
Interesting.
So that
And
is
go ahead.
definitely, I mean, heavier alcohol use is associated with specifically pardon me, it's a greater reduction in T3. I apologize. I misread
Oh,
that
okay.
statement. I was
No,
like,
it's all
ooh,
good.
I was looking for a link and I got ahead of myself.
Mhm.
It's all good. I was
Um,
gonna say, do you have a source? I was confused.
yeah, the other thing that might be happening, looking at the Pagana source, it does indicate that oral contraceptives might raise just T3. So we don't have a medication history here. We don't know what she's currently taking. Um, but I think it would be worth asking in general, but particularly for this lab result to just kind of see if we can figure out why that is elevated all on its own there.
Absolutely.
All right. So now that we've talked about how the labs don't indicate anything concerning at this time, and how we'll continue to look into the T3 levels, our plan and priority right now is creating a safe space for Maryland, creating using the Maloo therapy. So the plan for right now is initiate a Maloo therapy, which means giving her a place where she can feel safe and able to openly express her feelings without judgment. Also, try to reduce stimulation so that she can rest since she hasn't slept for a while. Um, And then it's also, as Stevie said earlier, it's important to note that she is under voluntary admission, according to ATI 2023. This means that she is able to recognize the need and willingly admits herself to the hospital. So the expected outcome for that, I think it would be that she will adhere to expectations of behaviors while on the unit. So maybe her complying more to expectations and being cooperative, especially since it's a voluntary admission. Um, since we are going to initiate the milieu therapy, she will be communicating her feelings and thoughts of suicide to the RN throughout the shift. Um, Safety measures that we are going to initiate is to make sure the physical environment is designed for safety by removing wires, curtains, hooks, bedding, limiting access to windows, and also having her change into hospital approved scrubs that do not have laces. So the expected outcome is that she will remain physically safe throughout the shift, because of the safe environment. Um, we will continue to monitor her vital signs to rule out any medical problems that might cause these manifestations. So as we've said earlier, we will continue to monitor these things, gather some more information about the medications she's taking. Um, and the expected outcome is for her vital signs to remain stable throughout the shift, especially if we do not find any other medical findings at this time. And then the next plan is for her to have a regular diet because, again, her weight loss is very important. We want her to try to eat a little bit more so that she has more energy. And overall, it can help her feel better. According to ATI, it is a protective factor. So the goal is for her to eat 50% or more of her meal tray at each meal. She will also be getting sertraline. Sertraline is an antidepressant, which will increase the uptake of serotonin neurotransmitters in her brain, according to Kreisman and Ernst Meyer. So this will help increase her energy, but it is very important to know that this places her at greater risk for self-harm. So as nurses, we should be looking out for those keywords like, I have the energy to do what I want now, or now I feel energized and I have a plan. An expected outcome is eventually at discharge, she will verbalize that it may take up to 4 to 6 weeks for antidepressants to take full effect. This is also according to Kreisman. Trazodone will also be used. It is a serotonin antagonist reuptake inhibitor. It is an antidepressant, but it is most commonly used for anxiety or as a hypnotic, according to Kreisman as well. Therefore, she will report feeling more rested upon awakening at the beginning of the shift. So hopefully she'll be able to get more sleep and feel better that way as well, because it's very important for her to get sleep. And then she will also be taking lorazepam to help decrease anxiety and or insomnia, according to Lippincott. This is to help with breakthrough anxiety. So therefore, she will report decreased symptoms of anxiety by the end of the shift.
I have a question for you all. Because of the mention of the hallucinations, let's say with her admission, we're able to rule out that these are not influenced by alcohol use, because that is very possible, or prolonged sleep dysregulation.
Mm.
What are our thoughts on perhaps approaching the doctor to discuss our concerns about the fact that she may be presenting with psychotic features? It may be that the doctor may want to consider an adjunct medication to accompany that SSRI, like typically something like Abilify, because she may need additional support in the meantime while that SSRI takes effect. And it's possible that the SSRI might not be the right fit for her medically, because not all of us respond the same way to these meds. It will really depend on her specific individual brain chemistry. So I would just really love to hear your thoughts on, um, you know, additional approaches to pharmacological therapy.
I agree with you on the condition that only if the hallucinations persist. I think that living alone and being severely depressed can definitely cause things like hallucinations, right? When you're alone and you're that unwell, um, it's easy to think crazy things. So I think being in a group setting and having more contact with other people is going to help her be a little more grounded in reality, hopefully. But if the hallucinations do continue, then yes, I agree that additional medication should be discussed.
Yeah, I agree. And probably just monitor and engage her and with like therapy and treatment, seeing if it subsides before we tackle on another medication.
Absolutely. I just kind of wanted to put that out there
Yeah,
for
Yeah.
discussion.
and thank you.
Yeah, yeah, no, that's really great. I think When I was doing research, to me it sounds like the main thing right now is to try to treat the underlying problems. And as everyone else said, let's see what happens if she gets more sleep, eats more, um, and stuff like that.
How do we feel about the use of lorazepam given this the suggestion of inappropriate substance use in her personal life? Because she was I know the term self-medicating with alcohol is a bit of an outdated term, but using alcohol inappropriately as a coping mechanism does give me some concerns about the use of lorazepam, even though it appears that it, may be indicated, but she doesn't appear to have manifestations of panic attacks.
Mhm. Mhm.
Yeah, she is displaying anxiety, but I agree with you that the interaction between the lorazepam and potential alcohol use is concerning. I think education to the patient before discharge would be absolutely essential, and just really making the impression that they cannot be mixed um, would hopefully be enough, but you never know.
I mean, it may be worth mentioning that while lorazepam may be an appropriate choice while she is admitted, a home prescription for such a potentially addictive medication that can really disassociate her from reality and cause her to sleep more. I mean, the pattern of prescribing benzodiazepines is definitely has definitely changed in the past 20 years.
Yeah. And I think that having the trazodone also in effect for the anxiety and to help her sleep, I think that probably just having that would be okay if she's still experiencing insomnia and anxiety with that on board, then she can talk to the doctor about adding something else. But I agree with you that the lorazepam should not be taken at home.
Yeah,
Trazodone.
and I think it's worth mentioning that both of those are ordered PRN. So I think the thing to do would be to start with the trazodone, see if that helps, and to keep a record of how often she is requesting that lorazepam. And if it is pretty often, then to have a conversation about, what might be going on there, and what other things might be helpful, because we do know that it's something that she's prone to or might be at risk for. But I don't think that we should necessarily avoid giving it to her while she is admitted because we can make sure that she's getting a safe dose and, all of that as long as we're on top of making sure she actually takes it, watching her take it, all of those things. I think it's safe while she is inpatient with us. I agree that at home is kind of a different beast and something to be discussed at that point. And then we'll also have the information of how often she was requesting it and what her reliance on it might be at that point.
It's a good point.
Yeah, those are all really great points. I have nothing else to add. Thank you for all of that insight, Aislinn. That's great. All right, so now we're going to move on to the nursing priority. As stated earlier, the nursing priority who is at risk for suicide is safety. So again, um, we are going to start suicide precautions. That means searching all of her belongings, determining what is safe and not safe. Um, Books are usually acceptable and okay to keep her occupied. And then we would store all the unsafe items away. Of course, it's very important to communicate with her and for her to understand why this is happening. So the expected outcome is for her to verbalize the reason why these precautions are taking place. And then we will also be doing one-on-one monitoring in the inpatient setting. This is to make sure that she is safe, that visitors do not take any unsafe items into the room. That is the reason for one-on-one monitoring. Expected outcome is she will comply with removal of items as well. Another very important piece is to consistently screen her for suicide by asking direct questions, asking if she is thinking about killing or harming herself, if her plan has changed. I know earlier she stated she didn't. Um, if if she would harm themselves, if she would harm herself if a situation such as a relationship or illness became worse. So we will continue to monitor, screen, and document all of these questions, and she will continue to communicate her feelings and thoughts of suicide throughout the shift. Let's see here. Another reason for the one-on-one monitoring is some inpatient units might not have. So another reason why one-on-one monitoring is beneficial is some inpatient units may not have direct access to the bathroom. So like the client might have to walk to the bathroom. So that person who monitors them will escort them to the bathroom or will escort them to other parts of the hospital for testing or care. So Marilyn will comply by walking alongside the escort to other parts of the hospital as needed. Another very important thing is for the nurse to check on Marilyn randomly every 15 minutes according to ATI. The timing may also be different according to facility protocol, but this needs to be random because if we are showing up at expected times, the client will be able to predict when someone will be there or not, and a suicide attempt may be timed for that opportunity. So those are the things that the nursing interventions that we will do to keep Marilyn safe while she is here.
Awesome. Alrighty. So looking now at some of the psychosocial priorities. So thinking about caring and comfort and how we're gonna show Marilyn and interact with Marilyn in a way that makes her feel like she matters to us. She is withdrawn. She doesn't want to answer a lot of questions. She has to be sort of prompted to speak. So it's important that we are spending time with her, even if she isn't choosing to speak with us. Sitting with her, hanging out around her, will just help express that she is important and we are invested in her care. So that will be one thing. Another thing is in interactions with her when she is speaking, we want to offer empathetic responses. We want to be concerned with what she's saying. And we really want to encourage her to share her feelings and thoughts. So it was mentioned before that she has mentioned that she has suicidal ideation. We do want to encourage her to speak about that with us, because when patients do talk about really difficult feelings like that, it can help them feel a sense of relief and a feeling of decreased isolation. So those are ways that she'll be cared for. Um, Finally, we want to include her in her care plan, um, especially since she's coming in voluntarily. We really want to encourage that. Like she recognized that she was in a dangerous place, so she brought herself to us. We don't want her to feel like she's now on lockdown and everything has changed and it's super scary. So we want to offer her as many decisions as we can. And these can be things like diet. We can't really change on a lot of things, a lot of safety stuff. But the things that we can, we want her to be included and we want her to be a part of it. Um, and the goal is that she'll feel respected and she'll feel like she is being able to participate. So for her physical comfort, um, one of the things that we're doing as a nursing intervention is monitoring her food intake. So a way to make that more comfortable is to have her do that with other people. Mealtime is normally social. So to encourage food intake, which will help her feel more comfortable, less, weak, fatigued, all of those things that come with not eating enough. We want to encourage her to be involved with the other people, to be out in the environment with the other people that are in the unit. Um, want to be so clear that this is so dependent on her ability to remain safe. To facilitate uninterrupted sleep, I would love to not disturb her for about 8 hours, something like between 10 p.m. and 7 a.m. This may not be where we start. She did say that she does not have a plan for suicide at this time. But we are obviously concerned because she has had those thoughts for what appears to be the first time. So we can start not there and see how the medications are helping her, and maybe she does sleep great and it goes wonderfully. But if she is complying with all of the safety measures that we have in place, and she's reporting that she's starting to feel better, she's reporting a lack of suicidal ideation, I think it would be great to really help her get a full night of rest. So that will be one that we can institute if it is indicated at the time. For emotional support, these are ways that we're going to develop that therapeutic relationship and maintain that during her stay. So one of the things that we'll do is make observations rather than ask her direct questions. Direct questions can be anxiety producing. They can make you feel like you're on the spot a little bit. So we'll say things that we see instead, something like, I saw you drew a picture today in group therapy, rather than what did you draw? Why did you draw that? Um, so hopefully this will encourage her to continue to communicate and to not shut down or withdraw. We will also clearly communicate the rules of the facility. And the intent here, as it relates to the therapeutic relationship and emotional support, is when you know what the expectations are, that can often be a comforting place to be. So she's in a new place, a lot is changing, and we want to explain that to her and have her feel comfortable what's going on. We don't want her to not really understand everything that's going on and feel like, oh, I don't know what I'm supposed to do. We're not going to use platitudes with her. These can be very minimizing. They can feel like we don't really care about what she's feeling or we don't recognize it with the gravitas that we should. So things like you'll be okay, everything's going to get better, those are going to be avoided. It can make her feel guilty, like it can make her feel like she needs to snap out of it and that she is wrong in some way for not being able to do that. So no platitudes while she's there. Um, we're also going to use simple words and allow Marilyn the time to respond to those. Simple instructions as well. And this is related to those memory issues, concentration issues that she's having, and stimulation. We don't want to overwhelm her. So the intent here is that she doesn't get overwhelmed. She feels like she understands what we're trying to communicate, and she's allowed the time to communicate back. And then finally, we are going to listen and watch for warning signs, suicidal messages, concerning statements. And this can be a little bit difficult while maintaining the therapeutic relationship. But I think an important thing to try and do with this one is we want to communicate that we are invested in keeping her safe. So we want to communicate that. We want to get her to talk about it. If it is coming up, we can make those observations and say, hey, I noticed this is going on, and just sort of end it there and see if she wants to engage. Hopefully prompt those feelings of relief and decreased isolation if she does choose to talk about it. Looking now at spiritual care. So it wasn't mentioned that she's religious in any way, or has any particular spirituality. So we should ask about that. It's a really great avenue for different support measures that we can give her, things that will help her during her time here. So we'll get more information on that. And then part of that conversation will also be to ask what is meaningful for her. So whether she has music that she loves, or she loves to draw, or she loves to dance. whatever is meaningful makes her feel like she's doing something worth doing. We really want to take advantage of that because those can be great things that make her feel like she's not so, it can help her feel supported and help her feel like she has a goal if she's working towards those. For cultural care, so we want to ask about any thoughts and what her thoughts are on depression treatment. It wasn't mentioned that she has any important specific culture, but there is a paper, Cooper 2003, that identified that African Americans statistically are less accepting of medication for depression. So we want to ask about that. How are you feeling about your treatment plan, about taking meds, about being here? That way we can figure out what stigma she might be battling with and how we can address that, work with it, what modifications can be made to help her feel as safe as she can and as willing to comply with treatment as she can be. Another thing I wanted to mention here was veteran resources. This will be a huge one for her. So there's a lot that the VA can do for her. One of those is to address her specific experience. They'll have lots of resources that will address her experience of transitioning out of the military, all the things that come with that that we just aren't experts on. The other important thing is that they will likely be able to help her navigate schooling and paying for it. Um, so we want to encourage her engagement with that so that she can work towards her goal and have that something meaningful that is keeping her going. So for discharge priorities, a decent amount of these were mentioned above in like some of the support stuff, so I'll go through those quickly, but there are some other ones. Um, One of the first things to talk about, it sounds like she doesn't have a history of depression. This is all pretty new for her. So we want to talk about noticing when she is getting depressed. Manifestations, we want to talk about anhedonia, the difficulty sleeping, her mood, indecisiveness, trouble concentrating, all the things like that. We want to encourage her to sort of put a pin in and just recognize when they are coming up, because that might indicate that she should come in and see us, or she needs to figure out something outpatient that can support her. We also will educate her on the use of a sleep tracker or a sleep diary. This goes hand in hand with the last one. Sometimes you just don't notice when your sleep is messed up, especially if you're having trouble concentrating. So I think that this would be a great way for her to track how that is going and kind of have a measure for herself of like, oh, I've been sleeping a lot less recently, or I woke up a lot in the past week. Maybe I should start to think about other things and like see what else is going on in my life. Um, Another thing that would be great for her to integrate for health promotion will be exercise. So according to ATI, 30 minutes of exercise 3 to 5 days a week is helpful and it can mitigate the symptoms of depression. So lessen them, it can be preventative. So that'll be a great just maintenance thing for her to do. Also setting up outpatient therapy. So for major depressive disorder, medication alongside therapy is really what's most effective. So it would be ideal for those two to be set up for her prior to her going home, so she doesn't have a break in care. But we will want both of those to be happening. So, a couple other things. We want to talk about her alcohol consumption. So the hope is that with the medication and with an adjustment to the inpatient facility, um, she'll sort of have a better sleep schedule and no longer feel the need to cope with alcohol. But we do want to talk about it and talk about how it can exacerbate the symptoms of depression. It is not a promising avenue to get to sleep. It does not lead to good sleep. It leads to worse sleep. And it's really going to exacerbate a lot of the things that brought her in. So we want to discourage alcohol. It would be great if she could eliminate it. Um, and then we will encourage the VA support. I talked about that a bit before. Um, and finally, one of the biggest safety things, we want to make sure that before she goes home, if she lives with family or anything like that, she has a neighbor that she trusts, we want them to remove the firearm from her house. So that can be taken to the police. It can be taken somewhere where it can be stored safely. But we want her to focus on managing her depression. We want her to be able to be safe while she does that. So a huge priority before we discharge her is to ask, where is the firearm at this present moment? We don't want her going home while it is still in her home. And that is all I've got.
Those are great. I really like the comprehensive approach to incorporating her outcomes within treatment to what discharge will look like. I think, you know, altogether, we've developed a really holistic way to approach Marilyn's challenges. And I I can't help but feel very hopeful for a positive outcome because she came to us, and in the outcome where we're stating that she's going to abide by particular behavior, setting expectations. I think that Marilyn's history demonstrates that she is someone who functions very well in a structured environment.
Mhm.
And if we can provide her with that, then it may allow her to kind of free up that cognitive space to really focus on herself. And if we take the difficult work out of navigating your own routine, well, we're going to provide one for you. We're going to help you kind of recalibrate where, you know, what your day is going to look like. And that will help equip her with a wide expanse of tools that she can use successfully. And especially, the mention of reaching out to the VA, because I love that, there was acknowledgement that we aren't experts. However, we have access to them and we can connect her with them.
Yeah, absolutely. And one of the things that I think is really promising in this case, which you mentioned, is she has good insight, she has good judgment. She's aware that this is different for her and that it's scary for her. And she's making the choices to seek help. So she wants the help, which is not always the hand that we're dealt. Um, so I think I agree that I think it's very promising. And if she shows good engagement in our interventions, I think she will. I think she'll be motivated to engage in them.
Like, I really respect the idea of, like, we're not going to engage in platitudes because I don't think they make anyone feel that particularly great. However, really acknowledging and demonstrating our value for that insight that she's shown, for the
Mhm.
bravery that she's shown coming forward, is going to be really important because that can be a foundation of building back her self-esteem.
Yeah, absolutely. And I think that's like essentially part of a motivational interview, right? Is saying like, here's something that I recognize. And this is something that is helping you in this case, which is like a good observation that will hopefully not make her feel diminished or minimized, but rather sort of bolster her and be like, oh, I am good at that. So, yeah.
Yeah, and it sounds like she has the support of her parents. She stated that she loves her parents and that's why she didn't have a plan. So that's so great that we can work with them too with discharge plans.
Yeah, absolutely. All right, wonderful. Any final thoughts, or are we feeling good?
Feel really good. I'm really impressed with the comprehensive approach we're going to take. I think everybody brought some really, really wonderful points to share to this meeting.
I agree. Wonderful. All right.
Go Team Maryland.